very common odontogenic tumor, which finds place not just in clinical diagnosis, but also in the questions of your entrance exams. And we refer to that as ameloblastoma. Now, before we go into ameloblastoma, you should know what are the possible origins for different types of odontogenic tumors. As we saw in our previous webinar on odontogenic cysts, we had seen different cysts arise from distinct populations of rest cells. Very similar to that, I had also told you in the first session that every aspect of tissue, every tissue has an epithelial component and a connective tissue component. This goes without exception even for the odontogenic apparatus. So there also you have an epithelial component which is derived from the ectoderm and a connective tissue component which is derived from neural crest cells which are called the ectomesenchyme. So that's the word used in odontogenic parlance for the connective tissue. It's called an ectomesenchyme. So you have tumors. So now you know there are two components. There will be an epithelial component and an ectomesenchymal component. So at any point in time, things can go wrong in the epithelium and in the ectomesenchyme. If things go wrong in the epithelium, there are a list of tumors which can arise. If they go wrong in the ectomesenchyme, there are other groups of tumors. So let's just see that in brief. So if the odontogenic epithelium is affected, you have four tumors. That's your ameloblastoma, your squamous odontogenic tumor, your calcifying epithelial odontogenic tumor, also known as the Pinbog's tumor, and the adenomatoid odontogenic tumor. So these are tumors that arise exclusively from the odontogenic epithelium. Then you have some contribution from the connective tissue, that is the ectomesenchyme. So epithelium plus ectomesenchyme with or without hard tissue formation. So by this term, what we are trying to tell you is the source of the tumor can be from both epithelium and ectomesenchyme. So at this point, you should have an understanding that a tumor or a neoplasm is something which is multiplying at an uncontrolled rate. So here what happens is, with regard to the odontogenic epithelium and connective tissue, these components are multiplying in an uncontrolled manner, but they are also retaining some degree of their memory genotypically. That is, some cells, for example, your inner enamel epithelial cells are programmed to give rise to enamel. However, if there is some genetic alteration in that, they will start multiplying in an uncontrolled manner, and some of this original function of the inner enamel epithelial cells gets lost, but they will retain some of it. So there may be some evidence of hard tissue formation. So with or without hard tissue formation. So you have ameloblastic fibroma, ameloblastic fibroodontoma, ameloblastic fibrodentinoma, calcifying odontogenic cyst, or the calcifying cystic odontogenic tumor. That's the new terminology. Then we have the odontoma and the odontoameloblastoma. So the easy way to remember this is, whenever you have two different combinations, that is ameloblastic, which is signifying epithelial origin, fibroma, connective tissue origin. Ameloblastic, epithelial origin, fibroodontoma, connective tissue. So like that, you have to split each term to decide what is the possible origin of that tumor. Then you have exclusively odontogenic ectomesenchyme derived. These include the odontogenic fibroma and the odontogenic myxoma. So please keep this in mind. When you are seeing this, you should recall what we have seen in our previous session also. Can somebody tell me which are the cysts, odontogenic cysts derived from the reduced enamel epithelium? We had discussed previously. Yes? Two cysts arising from the reduced enamel epithelium. Two odontogenic cysts. Reduced enamel epithelium. It will be dentigerous cyst and, yes, eruption cyst. Radicular cyst arises from the cell rests of molasses. Radicular cyst and residual cyst arise from the cell rests of molasses. Okay. KCOT or OKC arises from the rests of the dental lamina. Rests of dental lamina are also called, what's the other name for the rests of dental lamina? Come on. Rest of sere, very good. Rest of sere. What is the rest of molasses are remnants of which cells? Rest of molasses, yes, Hertwig's epithelial root sheath. So all these things should flash in your mind immediately, okay? Good. Which odontogenic cyst is associated with a non-vital pulp? Most commonly associated with a non-vital pulp? Good. Radicular cyst. Good. Okay. So let's move on. Now let's see the terms which are used to describe an ameloblastoma. Now, a scientist named Robinson was the one who described ameloblastoma with 4 words: unicentric, anatomically benign, clinically persistent, and non-functional. This has been asked exactly like this in an MCQ. So you have to know these terms at the back of your mind. So you should know what it is. Unicentric means the center or the point of origin. It's an intraosseous lesion. An ameloblastoma is a tumor which arises from within the bone. That's why it's called intraosseous. And it is unicentric. Unicentric means it has a single point of origin. And from there, it expands within the bone, destroying the bony trabeculae and spreading and expanding in size. Hence the term unicentric. It is anatomically benign. That means it does not show features of invasion. Invasion is a feature you usually associate with malignancies. So anatomically it is benign. It tends to move and spread aggressively. That is there, but it's not invasive per se. Then you have a feature called clinically persistent. That is, it does not show resolution on its own. It does not resolve on its own, unlike some other lesions. So you need to manage it surgically, and only then is the lesion going to go away. So it's clinically persistent, and most importantly, it is non-functional. That's the term I told you, that you should go back to the classification. You see that it is derived from odontogenic epithelium only. So the epithelial cells will undergo some sort of neoplastic change, give rise to the tumor. However, these cells are incompetent to produce the dental hard tissue or the hard tissue apparatus which you associate with the normal counterparts of those cells. So hence it is considered to be non-functional. So unicentric, anatomically benign, clinically persistent, and non-functional. Just remember what each term stands for. That will help you explain ameloblastoma better and will also help you understand these points much better. So now you should know what are the possible cells of origin. The possible cells of origin, to understand this, you should have a brief idea of how the odontogenic apparatus looks at the stage of development. Okay, non-functional. Okay, non-functional means it does not perform a function. That's it. So the neoplastic cells do not perform a specific secretory function which is commonly associated with the normal counterpart. Hence it is called non-functional. Okay, non-functional. Hope that's clear. Okay, so now let's move on to the possible cells of origin. So now you should know that you should have a brief idea of how the odontogenic apparatus looks at the stage of development. So for all reference, let's consider the Bell stage. You should have an oral epithelium or a basal cell layer here. Then you have an ingrowth of the basal cell layer which forms the dental lamina, which in turn forms the future tooth bud or the enamel organ, right? Now, this enamel organ undergoes varying degrees of changes called histodifferentiation, giving rise to distinct cell populations, each of which is capable of producing a distinct dental tissue. So these are the 3 players that you're going to see here. So either of these have been implicated with the pathogenesis of an ameloblastoma. So the basal cell layer remnants can give rise to it. The developing enamel organ can give rise to it, this part. This is the most accepted pathogenesis for the ameloblastoma, or it can also arise from remnants of the dental lamina, right? Among these, developing enamel organ, that is why ameloblastoma is more commonly called a neoplasm that arises from a developing enamel organ, because histologically the typical feature which you would associate pathognomonic to ameloblastoma resembles an enamel organ, which we'll be seeing in our histology. So this is the most accepted theory. Radiographically, it will present as a large multilocular radiolucency. Multilocular is, see this is one radiolucency here, one here, one here, one here, one here. Multiple locules. That is basically because the lesion as such, an ameloblastoma, is intraosseous. That is, it spreads within the bone. And as you know, the bone has trabeculae within it. Right? So these trabeculae get ruptured as the tumor spreads within the bone, leaving behind thin spicules of bone, which represent this typical soap bubble or honeycomb pattern, which is associated with a multilocular tumor like ameloblastoma. So these two terms should stick with you always: soap bubble appearance and a honeycomb pattern that is associated with an ameloblastoma. So this is how it appears. And the most common site for the appearance of ameloblastoma is in the body and the ramus of the mandible, usually in the posterior portion of the mandible. And usually it will be seen within the 4th to 6th decade of life. Now we move on to the histology. Histology is where most of the questions are going to come. So there is a histological criteria for making a diagnosis of an ameloblastoma. This is called the Vickers and Gorlins criteria. Now, Vickers and Gorlins criteria is important because ameloblastoma as a tumor has multifarious histological presentations. It can show different histological patterns. It has different histological subtypes, which we'll be seeing. So among all these subtypes, there are a common set of features histologically which need to be appreciated to give a better diagnosis of an ameloblastoma. So these 3 cardinal features have been compiled and categorized as Vickers and Gorlins criteria. So you have 3 features: hypochromatism of the nuclei of the basal cells, palisading and polarization of nuclei away from the basal membrane, and vacuolation of the cytoplasm, subnuclear vacuolization. Now this is very easy to remember because these are exactly the same features which you are going to see in a tooth bud, in an enamel organ. At the late Bell stage, this is what you are going to see just before apposition or laying down of the mineralized tissue begins. Histologically, this is exactly how a tooth bud will look. You will have an inner enamel epithelium here, lined by these tall columnar cells. You'll have the enamel organ lined by tall columnar cells, which represent your inner enamel epithelium. You will have the nucleus directed away from the basal lamina. Please follow my cursor. This is the basal lamina. The nuclei are directed away from it. This is called reversal of polarity. That is, the cell is preparing to deposit its contents or its secretory product, which is enamel. And subnuclearly, you will have vacuolization. So this is exactly how the tooth bud will appear. So if I can illustrate diagrammatically once. If you have it like this at your Bell stage, you're going to have these tall columnar cells here. Okay. Now, the nucleus, when it is ready for secretion, when the cells are ready for secretion, the nucleus gets pushed away from the basal lamina, this area, which later comes to be known as the membrana preformativa. Okay, so the nucleus gets pushed away from the basement membrane and the cells are ready for secretion. So eventually what happens is these cells will deposit a layer of enamel here and move upwards. Again, another layer of enamel, again move upwards. Incrementally, it keeps moving upwards, eventually forming a protective layer on the surface of the tooth crown, which later is known as the reduced enamel epithelium. So this is how normally things happen. In an ameloblastoma, what happens is these cells have formed, they have undergone reversal of polarity. There is some semblance to the normal histology here by way of subnuclear vacuolization. That is, vacuoles present here, which could be remnants of secretory granules. So when these things are seen, you can understand that this apparatus was ready to produce odontogenic substance. But that is when things took a turn for the worse, and instead of getting a tooth, what you're left with is a tumor. So these cells chose to multiply rather than lay down a matrix. That is when you get an ameloblastoma. Hope this concept is clear. Whenever you see any pathology, the first thing you have to do is split that term to get the cell of origin, ameloblastoma. So ameloblast is the cell of origin. Oma means it's a neoplasm. Next, you should know how a normal cell looks, how a normal ameloblast looks just before its secretion. And from there, you have to figure out the features which distinguish it from a benign tumor. Hope this is clear to you. Okay, so let's move on. Now we come to the histological subtypes. So there are 6 distinct histological subtypes. Among this, the most important one, which is the prototype for ameloblastoma histologically, is this first diagram. This is called a follicular ameloblastoma. A follicular ameloblastoma. So you will have large follicles like this. This is one follicle. This is another follicle. This is another follicle. So you have large follicles of neoplastic epithelial cells, neoplastic odontogenic epithelial cells, which exhibit the Wicker and Gorlins criteria. So a typical ameloblastomatous field will look something like this. On closer examination, it will look like this. So you will have a follicle. This is a zoomed in version of a higher power image of a follicle or follicular ameloblastoma. So you will have a basement membrane here. You will have the cells exhibiting Wicker and Gorlins criteria. You will even have cells within the middle which resemble a star-shaped population of cells seen in the tooth bud, which is called your stellate reticulum. Star-shaped stellate reticulum finger-like projections. So you have these thin finger-like interdigitations giving it a star-like appearance. So stellate reticulum-like cells are also seen. So that's the extent to which this tumor resembles a tooth bud. So that is what you will be seeing in a follicular ameloblastoma. Next, you have your plexiform ameloblastoma. Plexiform means it is being stretched. Plexiform means if something is being stretched. So this exact thing, if you take a follicle and imagine the follicle to be a balloon. If you deflate some air from it, you can stretch the balloon more, isn't it? When you inflate a balloon, you cannot stretch it much once it's filled with air. However, if you deflate it, what happens? You can stretch it easily, isn't it? So that is exactly what happens in a plexiform ameloblastoma. So here you have stretched out strands of ameloblastomatous epithelium. Yes, and these strands will exhibit the Wicker and Gorlins criteria. However, it must be noted here that histological features are a lot more difficult to discern in a plexiform ameloblastoma. Okay, so in such cases, you need to look for certain fields in that section which exhibit the typical Wicker and Gorlins criteria. That is very important. Any of these histological features, if you see, you have to look for the typical appearance of a ameloblastoma, which is the Wicker and Gorlins criteria. Only then can you give a diagnosis of ameloblastoma. Of course, then when there is, whichever is the predominant histology, you can give it a subcategorization based on that. So if more than 60 to 65% of the histology is looking like this, you can call it a plexiform ameloblastoma. Then you have another type which is called the acanthomatous ameloblastoma. Acanthomatous ameloblastoma is characterized by squamous cell metaplasia within the central cells. So look at this. This was a follicle. Okay. These cells, they still resemble these Wicker and Gorlins cells. See, there is tall columnar cells. The nuclei are showing partial reversal of polarization. Yes, reversal of polarity. But the central cells are not resembling your stellate reticulum-like cells. In fact, they are resembling squamous epithelial cells. Look at this, polygonal cells. Look at the degree of pink. I told you in the last class, look at the shape of the cell, the size of the cell, and the staining nature of the cell. Look at the staining nature you see here. And look at the staining nature you see here. See this? It's much more empty and you have a peripherally placed darkly stained nucleus. However, here you have polygonal cells with a much more prominent and pale staining nucleus, which resembles a squamous epithelium. You will also find remnants of cell death, which are called keratin pearls. Keratin pearls are usually formed as a result of faulty keratinization. So this in itself is suggestive of the lineage of these cells, which is squamous epithelial cells. Hope this is clear to you. This is called acanthomatous ameloblastoma. Then you have what is known as basal cell ameloblastoma. Basal cell ameloblastoma looks like the basal cell layer. Basal cell layer. So it will appear like flattened cells with a dark hyperchromatic nucleus and a scant cytoplasm. Very less cytoplasm will be present. So these cells will appear uniformly like this. So you will not find any features of Vickers and Gorlins here in these areas. Then you have to look for other sites. So this will be your basal cell type of ameloblastoma. Then you have granular cell ameloblastoma. In granular cell, what happens is the central cells assume a granular phenotype. That is, the cytoplasm in these cells appears granular. That is because of an accumulation of increased amount of lysosomes. So these cells have a very granular cytoplasm. This is how a granular cell ameloblastoma looks. Now what you should note here is these different subtypes are coming based on the changes that you see in the central cell population. This area, my cursor is there, this area. Changes in this area are what dictate which histological subtype you're going to classify this lesion into. If the central area gets stretched out and it's lost, then you call it plexiform. If the central area undergoes squamous metaplasia, you're calling it acanthomatous. Central area resembles basal cells, basal cell ameloblastoma. Central cells accumulate lysosomes and become granular, then you have it as a granular cell ameloblastoma. Got this concept? Now, you have another subtype which is called desmoplastic ameloblastoma. Desmo means connective tissue. Anywhere when you are seeing a term desmo, desmin is a marker or an indicator for connective tissue. So here what happens is desmoplasia. That means the connective tissue is much more active. That means there is a increased maturation of the connective tissue. That is, here if you see, look at the staining of the connective tissue here between these two islands. Look at this. It's so pale staining, isn't it? So it is very, very loose connective tissue. However, here, look at the density of the connective tissue fibers. It's much more eosinophilic or pink, isn't it? That in turn leads to the formation of, that is the characteristic of desmoplasia. As a result of this dense connective tissue, what happens is these follicles of ameloblastomatous cells will get pressed or compressed. Okay, so you will get small islands like this, which do not resemble an ameloblastoma. So it's very difficult to make a diagnosis in this case. So you have to search entire fields, go back to the history of the patient, the clinical history, the gross specimen, and then finally the histology to make a diagnosis. So these are the 6 clinical histological subtypes of an ameloblastoma. The prototype being follicular, then you have plexiform characterized by stretched out cords of neoplastic epithelium. Then you have the central population undergoing squamous metaplasia giving rise to acanthomatous, basal cell, granular cell, and finally desmoplastic. Hope this is clear to you. 6 histological subtypes. Okay. Now there are some other variants of ameloblastoma which you should also have an idea about. Okay, that will complete your understanding about this lesion. This is called the unicystic ameloblastoma. Now unicystic ameloblastoma occurs in much younger population, and it is a cystic lesion, and hence it is considered to be a slightly low grade lesion. Of course, it is having neoplastic potential, but it is low grade. This usually arises from pre-existing odontogenic cysts. And the most important odontogenic cyst which gives rise to an unicystic ameloblastoma is called the dentigerous cyst. The dentigerous cyst is the one which gives rise to unicystic ameloblastomas most commonly. Okay, so here the way to diagnose it histologically is, I told you in our previous session, every cyst has three components: lumen, lining, capsule. So here you have to pay attention again to the lining, as we did in our discussion in odontogenic cysts. So you have to look at the cystic lining. In the cystic lining, you will find features like this, typical of the ameloblastomatous nature. These cells on closer examination will look like this: tall columnar cells with the nuclei directed away from the basal lamina, and the suprabasilar layers, that is the layers above the basal lamina facing the lumen of the cyst, will look like stellate reticulum cells. Look at this. So this is typical. If this was in a follicle, you would call it follicular ameloblastoma, isn't it? So the same thing, when you see it in the lining of a cyst, you are calling it unicystic ameloblastoma. Simple as that. So this is usually seen in association with a dentigerous cyst. So please keep this in mind. Okay. Now, other than this, you should also know two distinct types of ameloblastoma, which are slightly towards the more dangerous side, associated with higher morbidity and mortality. They are called malignant ameloblastoma and ameloblastic carcinoma. Two distinct types. Now the difference here is, malignant ameloblastoma is also called metastatic ameloblastoma. Malignant, M for malignant, M for metastatic. Okay. Malignant ameloblastoma is also called metastatic ameloblastoma. Now the important feature here is, a malignant ameloblastoma is an ameloblastoma which occurs at any site other than your close approximation to the odontogenic apparatus. Other than the odontogenic region, if it occurs anywhere else, if you see a tumor arising at a distant site which exhibits features which are similar to the ameloblastoma, then you call it a malignant ameloblastoma. The most common site for this is at the lungs. The lungs forms the most important site for a metastatic ameloblastoma or a malignant ameloblastoma. So you will have the tumor there, and when you take a biopsy specimen and examine the histology, you're going to see features which resemble an ameloblastoma. That's why it's called a malignant ameloblastoma. Ameloblastic carcinoma, on the other end, remains within the odontogenic region itself. However, it has undergone carcinomatous change. That is, the cells will exhibit pleomorphic changes and a much more higher mitotic rate. So it will start behaving like a pure true malignancy. So it will start behaving like a malignancy. Hence the term ameloblastic carcinoma. So what you have to remember here is, malignant ameloblastoma histology does not change. Venue changes. Ameloblastic carcinoma, the address is the same, but histologically it is showing pleomorphism. So these are the two variants, malignant ameloblastoma and ameloblastic carcinoma. Hope this is clear to you. On that note, let's move to a few questions. Which is the most common odontogenic tumor? Yes. Good. Dr. Amrita is correct. It is odontoma. Odontoma is the most common odontogenic tumor. Ameloblastoma is the second most common odontogenic tumor. Please remember this. Odontoma is the most common odontogenic tumor. Ameloblastoma is the second most common odontogenic tumor. Okay. CEOT is also known as Pinbog's tumor. And calcifying cystic odontogenic tumor is associated with ghost cells. Ghost cells. We'll be seeing that in detail during our contact sessions. Okay. So remember here, it is odontoma. Which is the most common histological variant of ameloblastoma? Yes. Follicular. Very good. Follicular is the most common type. Granular cell is the most aggressive type. Granular cell ameloblastoma is the most aggressive type. Correct. You're right. It is follicular. The answer is follicular here. But granular cell ameloblastoma is the most aggressive histological subtype. The one which is most prone to recurrences is the follicular subtype. Follicular subtype is most prone to recurrences. Okay. Which histological, oh, I just answered it for you. Yes. Now you can tell me. Yes. Which histological subtype is most aggressive? It's the granular cell. What do the granules represent? What do the granules represent? Lysosomes, aggregations of lysosomes. Very good. Which type of ameloblastoma is characterized by cords or strands of neoplastic epithelium? Cords or strands of neoplastic epithelium? Plexiform. Very good. Plexiform. Good. Which odontogenic cyst most commonly gives rise to an ameloblastoma? Radicular. No, dentigerous. Dentigerous cyst. Dentigerous cyst. Okay. Dentigerous cyst gives rise to an ameloblastoma. Usually it's associated with unicystic ameloblastoma. Dentigerous cyst arises from which group of cells? Yes? Dentigerous cyst. Reduced enamel epithelium. Very good. Lateral periodontal cyst arises from? Lateral periodontal cyst. Come on. Lateral periodontal cyst. Same as KCOT. That's your clue. Same as the KCOT. Yes, rests of serrae, which are remnants of the dental lamina. And radicular cyst arises from? Radicular cyst arises from remnants of the Hertwig's epithelial root sheath. All this are also known as the rests of Malazes. Good. Which histological subtype presents with keratin pearls? Very, very important. Keratin pearls. Acanthomatous. This can also be asked which histological subtype presents with squamous metaplasia. Even then, the answer is acanthomatous. Okay. They can ask you which histological subtype of ameloblastoma presents with a hyalinized connective tissue. Hyalinized connective tissue. I told you in our first session when we were seeing different types of connective tissue, I said hyalinized means it's extremely dense, and because of that you don't find much of cells there. However, their secretions have been deposited to such an extent and have undergone so much maturity that it resembles a glass-like appearance, uniform glassy appearance. That is called hyalinized, which you see with desmoplastic ameloblastoma. Okay. So here, histologically, the most difficult to diagnose would be your plexiform and to a certain degree your desmoplastic ameloblastoma, because the follicles are completely compressed or stretched out. So hence, it's difficult to discern your Wicker and Gorlins criteria to make a diagnosis. Hope this is clear to you. Yes? So these are the things. Which part would you like me to repeat, Dr. Shruti? Hyalinized? Okay. Okay. Which type presents with keratin pearls? See, keratin pearls are a result of squamous metaplasia. That means metaplasia means one cell population undergoes differentiation into another cell population. So the central cells within the follicle are undergoing squamous metaplasia. That is, they resemble squamous epithelium. When they resemble squamous epithelium, they are not supposed to be there. They don't belong within that follicle, isn't it? That's not the house for the, that's not their address. So when that happens, they undergo faulty keratinization and eventually cell death will occur. This leads to the formation of a keratin pearl. This keratin pearl is associated with acanthomatous. Another thing which can be asked is which type of histological subtype can present with a hyalinized connective tissue. Hyalinized means the connective tissue is so mature that it acquires a glassy appearance, glassy histological appearance. So it looks like glass, much more uniform. This is called desmoplastic type of ameloblastoma. Okay, hope this is clear to you. Better now? Okay, good. You're welcome. So on that